I was so pleased when I saw who I was going to introduce this afternoon. Lucy, I sort of Googled her, and an inspiring, living with a life-limiting condition, a strong advocate of advanced care planning, getting involved in the voluntary sector, working with Together for Short Lives, a patient advocate, getting an MBE at the age of 22. Great lady. So Lucy, it's a great...
Yeah, so thank you for having me here today. I'm really excited to be here. And I wanted to start off with a question, and that I want everyone to think about today throughout the rest of the afternoon, especially if you attend my workshop later, and to reflect on this and then your own skills. You know, if you were the patient, what would good communication look like to you? It's really important that we all think about personalising communication. You know, it's not one approach for every patient, it's got to be personalised. And I'm delighted to be here speaking and sharing my experiences as a patient leader, about communication in my own care, and more generally about how communication can be improved in healthcare. And I hope you'll find my speech useful. So, get back. So who am I? As you know, I'm Lucy. I'm 25 years old and I have a life-limiting illness. It's actually a rare form of mitochondrial disease. So we don't know which form, but we know it's a mitochondrial disease. And I didn't actually find that out until last year. It's taken 25 years to find out what's wrong with me. And it's caused complex medical needs, physical disability, and obviously it's going to shorten my lifespan. It means I depend on a lot of interventions to survive, so I have a lot of round-the-clock care. I'm on TPN, so I'm fed via a line straight into my bloodstream. I also have nutrition, fluid and medication through that line. I have a PEG, which drains my stomach continuously, as well as 2 stoma bags. And I also have respiratory muscle weakness, so I have breathing treatments on top of all my other care. And as you can see, I use a wheelchair and have an assistance dog, Molly, who is a big part of my life. She's wonderful. But she thinks this is all for her, by the way. You are all here for her. So if you make a round of applause, that's hers. Yeah. Yeah. She's got a wag of the tail. There you go. And my condition will shorten my lifespan, and I've known this since I was 17. I actually skirted around this conversation for quite a long time, so I probably would have known a couple of years before, but at 17 I was told my condition was going to prematurely end my life. I wasn't expected to see my 18th birthday, and I exceeded that, and then I wasn't expected to see my 23rd birthday, and I've exceeded that. I'm 25 and I've got a lot of living yet to do. And my condition means I have a massive team of professionals involved in my care. You know, I have various different hospitals, various different professionals, different specialisms, and it means I've met so many doctors and nurses and allied healthcare professionals and received communication from them. And that doesn't include, all the cooks, the cleaners, everyone that is part of the health service. And I can hand on heart say I have the most amazing team of professionals who we can all learn from in the way they communicate with me and manage my care. They communicate with me as the patient well, my mother, who I have asked to be involved in my care, which is really important. And they've done a great job in making sure I have all the information I need, the support I need and the care I need. And I'm not saying I have all the answers and a recipe for good communication, but I hope sharing some of my experiences can give you some tips, hints and useful information today. And you can take something away from my speech. So there's a lot of work going on at the moment around communication in the Hello, My Name Is campaign, which everyone knows about introductions when you meet a patient and introducing your role by the late, great Kate Granger and obviously Chris Poynton. There's also the big drive to reframe the conversation and the narrative from what's the matter with you to what matters to you. And this is crucial for every patient to be seen as a person and to personalise our care. This ensures that we're giving the patients a good experience of care and it meets their needs and their wishes. They're at the heart of what they want, of their care. And for many of us, our illness is actually formed a very small part of our lives. We just want the care we need to go on and live and do the things we want to do. And it's about making sure we have those the tools and the skills and the care we need to do that. And I have an amazing team, as I've said, who truly embody this. My care is built around me, my life, my wishes. They're always asking me if there's anything more they can do to support me, and if there's anything else they can help me to do. And it's changing the narrative to what matters to you. It frames the experience in a positive light from the beginning. It makes sure that the patient is seen as a person first, not an illness. Because remember, you can't communicate with the disease, you can only communicate with the patient living with it, and that's really important. And one of the biggest conversations that I've had, and one which no doubt worries everyone in the room, is around end of life. You know, they're often not done well, or they're very anxious times for both patient and the staff. And I'm extremely fortunate that the conversations I've had about my condition being life-limiting, being given a prognosis and discussing my end-of-life wishes were done very well, very sensitively, very compassionately, and were well supported. And the first had room for improvement, as you'll see, but they've all given me a good experience. So the first time we found out that my condition was going to shorten my lifespan could have gone better, but I nevertheless feel it was a good conversation. So my consultant came in, he was talking to us about what was happening, and in this conversation he somewhat blurted out that my condition was going to shorten my lifespan. He was saying to me that me and my mum that my condition was going to keep getting worse and that they'll do everything they can to keep me alive and keep me well, but we needed to prepare for the fact that I wasn't going to live a long life. And don't get me wrong, the conversation was not lacking in compassion or support or kindness, but it was almost like my consultant had built up this big anxiety about saying it, that when it actually came to saying it, it just kind of fell out while he was speaking. And I think, you know, for him it was quite difficult, but also for us it was a huge shock. My life had been so much about keeping me alive for as long as possible, and suddenly they were saying to us that actually, despite our best efforts, you weren't going to live forever. You know, everyone wants to live forever, and everyone thinks the NHS is going to save you no matter what, but actually we've had to learn that's not the case. And it's just a huge shock, you know, to say to a 17-year-old and their mother that, you know, your daughter's going to die, you're going to die young. But I also feel like maybe my consultant might have had a bad experience giving an end-of-life conversation. He might not have had the support he needed. Maybe if someone talked to him beforehand, or even one of the nurses had been there with him, he might have benefited from some support in delivering that prognosis. And there was another conversation about my survival that I actually wasn't part of at the time, and I'm quite glad. So when I was put on TPN, my mum took my consultant aside and thanked him for all he was doing to save my life. And the consultant said that I wasn't actually expected to survive at all. I'd been left so long with malnutrition and a body that was failing, bone marrow failure, you know, I had a heart attack, I had all these complications. And I am quite glad that he didn't tell me that he only told my mum, because at that time, our big hope was TPN for keeping me alive, and I feel maybe if I'd been told, even with TPN, I wasn't going to live, that perhaps I would have had less fight in me, I wouldn't have fought so hard and had that want to live. And it's not that I didn't want to know, because I'm glad I knew a couple of weeks later, but actually it's the right information at the right time. And, you know, sometimes knowing when not to communicate something is as much important as it is to know when to communicate it. And I'm not saying to withhold that information, but make sure it's the right time, the right place, with the right people. So I was already under the hospice and palliative care team at this point, and they were fantastic. We did my first advanced care plan with my palliative care clinical nurse specialist when I was 17. And Beth, my nurse, made this a really positive conversation. It was as much about my life as it was about my death, and that was really important to me. She had asked in her previous visit whether she could come over and do some paperwork with me, and she explained what an advanced care plan was and why it was important, and it was about making sure that my wishes were heard and respected in my care. When she came that day, we did an update on all my health, so I updated her on what appointments I'd had and what professionals had said and how I was doing and what I was up to. And then she suddenly kind of turned the conversation, and it wasn't direct questions like, where do you want to be when you die, or what matters to you? She more gave different prompts, you know, perhaps asking me whether I'd thought about my end of life, whether there was any thoughts or wishes I had, what mattered to me in my life and my end of life. Had I ever thought about where I'd want to be? And she also asked me, had I ever thought about a time where I might not want treatment, and in what circumstances those might arise? She wasn't direct at all. It wasn't even specific questions. She was more prompting the discussion and then letting me speak freely, as much or as little as I wanted to. She didn't limit me. She didn't steer the conversation. She was making notes of things as I went along so she could actually record my wishes in my own words. And she listened to me, and she sometimes asked me to go back over something I'd said to make sure that she understood what I meant, or that I could expand on that a little bit. And she never once interrupted me or tried to stop the conversation. Actually, the amount of talking she did was minimal. You know, she did very little talking, apart from prompting and questioning when perhaps she wanted to know more. She didn't really talk that much. And Bev finished the meeting with asking me if there's anything else I wanted to talk about or any questions I had to ask. And then she went away and wrote up the advanced care plan, and she brought it back to me, written up, and said, if you read through this, make sure it's your life, your wishes, your words. Make sure I've captured what you want to say. And at this time, I elected not to do a DNA CPR or an advanced decision because that wasn't right at the time. But now we're updating my advanced care plan and we're having these conversations because 8 years on, a lot has changed. And I can honestly say it was a very important conversation, and it wasn't just about the end-of-life section. So the conversation allowed me to specify what my end-of-life wishes were. It allowed me to grieve and come to terms with what was happening and to talk through that. And it also gave us the tools and the permission to talk about end-of-life and death and dying. It removed the taboo. It gave us the language and the confidence we could talk about it. You know, giving people permission to talk about death is a huge thing, and it's your job as professionals to open that door and give us the permission. You know, a lot of people feel that somehow talking about dying will make it happen, or it's about giving up, and it's actually you as professionals saying, it's not about giving up, but actually we need to think about this, and it's about your wishes. And also the thing to remember is that end-of-life conversations are as much about living as they are dying. My end-of-life conversation was brilliant, it really was, and it should focus on wishes of life as well as wishes for death, helping the person think about what they really want to do in the time they've got left, what really matters to them, what things they feel they need to do, complete, or conversations they need to have, plans they need to put in place, and how they want their end of life to pan out, what treatments they do and don't want, and what their limit is, but also what life actually means to them. So at what point is your life going to become not your life and become intolerable, and where that limit is? At the end of my advanced care plan conversation, my nurse Bev said to me, so what do you want to do now? What matters to you? And no one had ever asked me that before. No one ever asked about what I wanted for my life now, what I wanted to do with my life. And it transformed my life. It led to the catalyst, that conversation was the catalyst for me starting my work. And that really has transformed my life, and that's why I'm here today. The next big end-of-life conversation we had revolved around my new prognosis at 18, since I already survived longer than I was expected to. And this conversation was also done brilliantly, despite being a conversation about my death and the reality of my illness. It was done in such a way that it was pragmatic, but it was compassionate. It was supportive and reassuring, and we look back on it as being a positive experience. So my consultant visited us at the end of his shift in his own time, and he spent over an hour with us. And he came in and we updated him on everything that was going on, all the professionals I'd seen, what was happening, and I was inpatient at the time. And he said we needed to talk about something. Was it okay if we talked about it now? So he gave us the permission to say, look, we don't want to talk about it now. And he went on to reflect back over everything that had happened, the complications, the surgeries, the infections, and how we weren't able to manage things as well as we would hope, and that there were few ways of actually managing these effectively. And he asked us if we had anything we wanted to ask him or anything we wanted to say. And as the conversation developed, he took my hand, he sat next to me on the bed and he took my hand and he said, we've talked about things getting worse. Unfortunately, we're not always going to be able to resolve issues when they arise, and we can't stop things getting worse. Your condition will continue to deteriorate and we cannot do anything to stop it. We don't know how much longer you'll be able to survive these complications. And of course, my mum jumped in and said, well, how long? And he said he didn't know. So my mum said, 10 years, 5 years? And he said 5 years at most, which would have taken my prognosis to 23. And I far exceeded it, but obviously I might not have done. And there have been many situations where I could have died, surgeries, complications, infections, and I've also survived sepsis 14 times, so that's quite an achievement, but not one I want to have. And he communicated with us so gently. He stayed beyond his shift. He answered our questions. He talked person to person, not professional to patient or professional to carer. He talked as 2 people or 3 people in a room with mutual respect. He made sure all our questions were answered. And in a strange sort of way, the way that was done was so compassionate and so supportive. It was a positive experience for us. We can look back and say we had a positive experience, a positive conversation. And now we know why they're called difficult conversations, but are they really difficult? If we have the right approach, the right person delivering it, at the right time, we have the confidence, the compassion, the necessary time to give, and the support in place for the patient, we can remove the difficulty from the conversation. But also you as professionals have the support you need in delivering those conversations, that you've got time to prepare in advance or to debrief afterwards. That's equally very important to give you a positive experience of that conversation. So what would I say to advise professionals on end-of-life conversations? Take your time. I know you're often pressed for time and it's really difficult, but don't try to deliver a prognosis or difficult conversation in a rush. It's never going to give a patient and their carer a good experience in that situation. I'm also a big believer of being honest. I truly believe knowledge is power, and I know some patients don't always want to know, but they can be empowered if they have that information. And we need to have the right information to understand what's happening, the language to describe what we're feeling, what we're experiencing, and to prepare for the future. And I believe in honesty and that knowledge are crucial, but actually I also believe in there being a right and wrong time to deliver information. And that I mentioned earlier, that consultant not telling me that TPN was not expected to keep me alive, not telling me that was what was right for me in that moment. Obviously my mum knew, but a couple of weeks later we discussed that when it was the right time for me. And I know there's never going to be a perfect time to tell someone they're dying. It's not a lovely conversation, but there is definitely a wrong time and a wrong place and a wrong person. And it's also important that you know your patient. You can respond to their unique needs, make sure you know them, you respond in the way they want to be responded to, you use the language they're comfortable with. They've got the option to have who they want there. And that very much depends on the individual, what their needs are, what their wishes are, and what they feel is important to them. So try, when you talk about end of life, to ensure you open the discussion for end of life conversations when the family leave that appointment. So it's not just about that appointment at that time, but that family can go away and talk about death and dying because it's okay. They've been given that permission. And sometimes the greatest signal of an end of life conversation is when the professional does as little talking as possible. And it allows people to talk as much or as little as they want without stopping them or directing them. Never cut them off. Do not steer the conversation. Let the patient talk in the way they want to talk about the things they want to talk about. Try not to limit what they're saying. And also give them time to ask questions. And it's actually okay to, at the end of that conversation, reflect on what you've heard, what they've said, and what you understand. So you know what the patient have said, but also the patient knows you've understood and heard what their wishes are and what they want you to hear. And you know exactly what matters to them. So good communication requires understanding the impact of what you're going to say on the patient and family. And that's a big part of communication. It's also about listening and letting the patient speak. It's about talking to them on the same level. I talked about my consultant. It wasn't professional to patient. It was two people in a room with mutual respect, mutual support, talking about a very difficult subject. It's also about giving them the platform to speak and ask questions, allowing them time to process. So if you ask a question, if they go silent, give them that time to be silent. They're thinking, they're processing, they're accepting it, and adapting your approach to their unique needs. So even if you don't know a patient and you are delivering a prognosis to a new patient, watch their body language, listen to what they say, how they respond. You can tailor your approach based on all of that. And it's about reframing the narrative from what's the matter with you to what matters to you. And I always say in my speeches, positive communication has an impact even when the news is bad, and negative communication has a bad impact even when the news is good. So actually, you can say something horrendous to a patient but still give them a good experience for good communication. But you can also give someone a bad experience even when you're telling them a good news if you don't do it well. And I hope you found my speech useful. I'm leading a workshop later, so if you'd like to talk more, ask questions, please do come along. We're going to have a very relaxed, informal session talking about communication. So hope you found this useful, and thank you.
Thank you so much, Lucy, and very professional, exactly sticking to 20 minutes, so that's very, very good. Did you want to take questions now? Is that what you're... So I'm being prompted from the front, you can tell. Story of my life. Does anybody want to ask questions now? We've got some microphones hanging around. Or you may want to keep them for the workshop, which would be fine as well, but does anybody want to ask questions now?
Can you tell us about your dog, Molly?
Every time I go to a conference, someone always asks me about the dog at question time. So Molly, she's 6, she's a Cocker Spaniel, and we got her just 6 years ago last month as an 8-week-old puppy. As a family pet, she wasn't meant to be an assistance dog. We had no intentions of her working. And when she was 10 months old, she was accepted to the charity Dog Aid, and they trained the disabled person to train their pet dog. So I'll let it go. There you go. So they train the disabled person to train their pet dog by matching you with a volunteer trainer. And for me, that was very empowering because... There you go, Molly's going to go and say hello now. It's very empowering because you're giving the disabled people the tools to train their own dog in their own way to their unique needs. And for Molly, she loves her job. it's one of her favourite things to do. And, you know, she's always waiting for tasks. You know, if there's nothing to do, she will make a task. So if I've got papers on my lap, she'll push them off to pick them up. And when I'm at events, she becomes everyone's assistance dog. So if you drop anything, she'll give it back, don't worry. But she can load and unload the washing machine, which everyone loves. You know, she can undress me, she can fetch help in an emergency, open doors, drawers. But also she alerts me 3 to 4 hours before I'm getting septic or a severe infection, which gives us, you know, for us, I always go to my hospital in London, so 3 hours gives us time to pack up, get to London, get to A&E and get treatment. And she's amazing. She loves her job, she loves to work, and she's independent. And the other thing, if I drop something for the 10th time and I've got a human carer looking after me, it's, sorry, I've dropped it again. For her, the more times I drop it, the more fun the game. So it turns needing help on its head, because actually the more help I need, the better it is for her.
Thank you. There's a dog which goes around the hospital where I work as a chaplain, and the dog does far more good in the hospital than I do, I always think. Comes from the day before. Thank you so much, Lucy. It's been great.